In this section, we are going to discuss on the COPD treatment. Before going to the COPD treatment, it is wise to understand the severity of the disease, because based on the severity only we are going to analyze and give the treatment. The first system that assesses the severity of COPD is called GOLD. GOLD stands for Global Initiative for Chronic Obstructive Lung Disorders. This is what we call it as GOLD. First of all, you have to know there is some entry criteria to enter into GOLD. The entry criteria to enter into GOLD is FEV1 by FVC ratio of less than 0.7. This is what we call as Tiphanew-Pinelli index, less than 0.7. So without this, you cannot even enter this GOLD criteria, which means there should be airflow limitation to enter GOLD. And that makes sense because without airflow limitation, you cannot even diagnose a COPD. As simple as that. So GOLD will use only one value, that is FEV1, to classify the severity, where they tell GOLD 1, where the FEV1 will be more than or equal to 80%. Please note the fact it's not FEV1 by FVC, it is FEV1 only. GOLD 2 means it is in the range of 50 to 79%. GOLD 3 means it is in the range of 30 to 49%, and GOLD stage 4 means it is less than 30%. And at the same time, your FEV1 also tends to correlate with the symptoms to an extent, where the patient will have mild symptoms with GOLD 1, moderate symptoms with GOLD 2, severe symptoms with GOLD 3, and very severe symptoms with GOLD 4. But what they later on found out is patient who's designated as GOLD 1, who's having FEV1 of more than 80%, still they, as predicted, they are not having mild symptoms. Instead, they have more severe symptoms. So that is the reason, since GOLD is not exactly correlating with the quality of life and the severity of the disease in reality, they started assessing the importance of new classification systems. One of the important new classification systems is Combined COPD Assessment Tool. Combined COPD Assessment Tool. According to Combined COPD Assessment Tool, you can put COPD into 4 classes: Class A, Class B, Class C, and Class D. So that's why this Combined COPD Assessment Tool is also referred to as ABCD tool. And currently, based on this only, we are going to give the treatment. What do you mean by Class A? Class A patients will have low risk and low symptoms. Class B patients will have low risk but more symptoms. Class C patients will have high risk but low symptoms. Class D patients will have high risk and high symptoms. Which means I can clearly tell Class A and Class B patients tend to have low risk, whereas Class C and Class D patients tend to have high risk. So what do you mean by low risk? Low risk doesn't mean anything, which means the patient should be in GOLD class 1 or 2. This is what we call low risk. At the same time, patient will have less than or equal to 1 exacerbations per year. So this is what we call low risk. What do you mean by high risk? High risk means the patient will be in GOLD class 3 or 4. At the same time, patients will have more than or equal to 2 exacerbations per year. So this is what we call high risk. And next, you have two other important tools. GOLD A and C, this A and C group will have low symptoms, but this B and D patients are having more symptoms. So what do you mean by less symptoms and more symptoms? Less symptoms is assessed through 2 important tools. One is called the MMRC tool, Modified Medical Research Council tool for dyspnea, where your MMRC scale will be in the range of 0 to 1, and there is something called a COPD assessment tool questionnaire, where it should be less than 10. Clear? So this is what you mean by less symptoms, which means category A and C patients are going to have less symptoms. What do you mean by more symptoms? If the patient has a MMRC scale of more than or equal to 2 in dyspnea scale, and or CAT assessment score of more than or equal to 10, which means patient is having more symptoms, which means B and D group will have more symptoms by definition. So this is how you classify. Very, very, very simple. A, B, C, D. Recap. A means low risk and low symptoms. B means low risk but more symptoms. C means high risk but low symptoms. D means high risk and high symptoms. So In that, they might be surely asking you, what do you mean by MMRC scale? MMRC scale 0 means absolutely no dyspnea whatsoever. And one important thing about MMRC grading is it should be used only for COPD purposes. You should not use this MMRC tool for other dyspnea conditions. For example, a common myth among the undergrad students is MMRC is for respiratory conditions causing dyspnea and NIHA is for cardiac conditions causing dyspnea. It's absolutely wrong. NIHA is for heart failure related dyspnea only and quality of life assessment. MMRC is for quality of life assessment and dyspnea assessment for COPD patients only, because it's validated only for that purpose, not for any other disease. Clear? One stands for shortness of breath during serious exertion. At very high level exertion only they get shortness of breath. And grade 2 means they will get shortness of breath while hurrying, while increasing walking pace. Only during increasing walking pace. Otherwise, at normal walking pace, they won't get dyspnea. Or when they are running uphill, when they are going above the, slanted place, like when you are walking uphill, they might get dyspnea. Grade 3 means your dyspnea will limit the walking pace, which means their walking pace will actually decrease because of the dyspnea. They cannot walk at their usual pace. In grade 2, they can walk at the usual pace, but increasing walking pace only will cause dyspnea. But in grade 3, they cannot walk at normal pace itself. They have to slow down their walking pace because of the dyspnea. Grade 4, they have to stop walking at 100 meters because they cannot even walk 100 meters because of dyspnea. After that, they will get dyspnea. Grade 5, typically homebound patient, which means that they cannot move out of the house because of dyspnea. Completely house arrested. Disease has house arrested the patient. And similarly, you have this CAT questionnaire. This is a quality of life assessment questionnaire, which means it's going to assess a lot of parameters that assess the quality of life of COPD patients. Typically, if you have a CAT, 8 questions in CAT, COPD assessment tool, each question will carry a score of 0 to 5, which means the total score will be 0 to 40. In that, less than 10 means they're having a reasonably good quality of life. Anything 10 and above means they're not having that good quality of life, in fact, a poor quality of life. So that's what it means. So this is a COPD assessment tool questionnaire. So these are things you're going to do. Now, based on this, how you are going to use the treatment. So again, you put 4 classes, A, B, C, and D, and let us see the treatment. So you have the first line treatment and you have alternative treatment. So what are you going to use? First line treatment, typically no regular treatment is needed for these patients, which means no long-term treatment, no regular treatment, and these patients need just frequent assessment with spirometry and routine clinical visits. Apart from that, they don't need anything at all, no regular treatment. Typically, category B patients need only monotherapy most of the times. We use long-acting bronchodilators. Either we use a LABA, that's called long-acting beta-2 agonist, or a LAMA, long-acting muscarinic antagonist. So typically they need one long-acting bronchodilator per day. That's it. Category C, again you need monotherapy only, but usually we go with the LAMA first. Again monotherapy only, but here typically we go for LAMA first, which means there LAMA in category B, but here only LAMA should be used as first line. So long-acting muscarinic, that's because of the proven efficacy of muscarinic antagonists in COPD compared with that of the asthma. We discussed in the last video itself. And in category D, you have to use dual therapy. You have to use double treatment, no longer mono treatment. And here you will use either a LABA and a LAMA combination or a LABA plus inhaled corticosteroid combination. But remember, we prefer this LABA and LAMA only because COPD related inflammation will not respond that well to steroids. And what are the alternative treatment? Alternative treatment you can try in case of persistent symptoms, which means you can move ahead in case of persistent symptoms. What are the alternative treatments? Alternative treatments, typically you do combination therapy here. In this case, LABA and LAMA together you can use. In this case, you can use a LABA and a LAMA, LABA and a LAMA, followed by LABA plus ICS. So this you can use. In this patients, again, you can use triple therapy because already these patients are double. So you can move on to triple therapy like LABA plus LAMA plus inhaled corticosteroids. Plus at the same time, you can consider other options like roflumilast. Other options like roflumilast can be considered. But anyway, so these are the typical cases. Remember, whenever you have a monotherapy, in case of persistent symptoms, push to double therapy. Whenever you have a double therapy already, in case of persistent symptoms, push for triple therapy. Very simple. This is not something very difficult. Remember, first line treatment, if they ask you, category A, no regular treatment is needed. Category B, you can use a monotherapy. Category C also you can use a monotherapy. In category B, either LABA or LAMA, but category C strictly go for a LAMA in the first place. And category D patients go for dual therapy. Typically, we prefer a LABA plus LAMA, or alternatively, you can use a LABA plus ICS also, but generally not that much preferred. Instead, you go for a LABA and LAMA dual therapy. So this is how you treat a COPD. Remember, in all these categories, all these patients, this A, B, C, D, I told you, all this category patients will be needing a PRN, short-acting bronchodilators. They need PRN. All this category of patients, all 4 categories will be needing a PRN SABA, short-acting bronchodilator. Let me put in a different color. So they need a PRN, short-acting bronchodilators, which means as required. Whenever they feel that they are dyspneic, they can take a puff of short-acting bronchodilators. Most commonly used short-acting bronchodilators are SABA. Or some people can prefer a SABA plus SAMA combination. This is a short-acting muscarinic antagonist. Some people can prefer a SABA plus a SAMA combination also. But most preferred is the SABA, where typically you take the Astalin neb, isn't it? Salbutamol neb, salbutamol inhaler, levosalbutamol inhaler, Astalin, Levolin. All these things are typical inhalers. So you can use as a PRN. PRN means as and when required. PRN stands for Prorineta. There is a difference between PRN and SOS. SOS means use only in times of emergency, and PRN means use whenever you need it. There's a lot of difference between them. Here it's a PRN, which means whenever you need it, you use SABA. Or alternatively, you can use a SABA plus SAMA combination also. At the same time, all these patients also need, all 4 categories need smoking cessation. Remember, this is a very, very, very important point. Remember, there are only 2 things that alter the natural history of COPD and improve the life and survival of COPD patients. One is smoking survival, and second is long-term oxygen therapy, LTOT, which we'll discuss in some time. So smoking cessation is really, really important. Because at the end of this video, I'm going to show the Fletcher and Peto curve, where you will understand the importance of smoking cessation very nicely. The smoking cessation is one of the very, very important treatment. This is the one that gives to maximal benefit. If they ask you the best treatment that you can ever do and increase the life survival of the patient, that is smoking cessation. That's it. Clear? This is the only treatment that can maximally increase the survival in COPD patients. Clear? And all these patients has to go for vaccination because the patient is having underlying chronic lung disease. So they are prone for pneumococcal influenza and all these infections. So you have to give a pneumococcal vaccine and you have to give a influenza vaccine yearly. All these things are again important. And again, proper education is important, especially for the inhaler use. And correct inhalers you should use. You should instead use mist type inhalers rather than using a Rotacap type inhalers and all. Because Rotacaps and all we don't prefer in COPD patients because their vital capacity will already be low. Already they will be having poor elastic recoil and they cannot generate sufficient amount of force. So because of that, they cannot use this Rotacap, which needs power to make it into powder form and inhale. So please use mist forms, clear, or sprays. So that is much better because they don't need any much, work to break down the tablet or something. So, again, depends on what your expertise level is. So give those kind of inhalers. So these are the things that you have to know. But let us move on and see what are the agents that can cause bronchodilation, bronchoconstriction. So you have a bronchus, which can go for either bronchoconstriction or it can go for a bronchodilation. For bronchodilation, the most important receptor type you need is the beta 2 receptor in the lung, and which is going to be activated by sympathetic system. And how beta 2 system works, they increase the cyclic AMP levels. By increasing the cyclic AMP levels, they are going to produce bronchodilation. And this cyclic AMP, they are actually degraded by an enzyme called phosphodiesterase. This is the micro mechanism, small mechanism. And what about the bronchoconstriction? Bronchoconstriction is typically produced by M3 receptors, muscarinic receptors. And typically this is acetylcholine vagus mediated. So this is going to cause bronchoconstriction. Apart from that, there are a lot of other agents that can cause bronchoconstriction. For example, you have arachidonic acid that is broken down into prostaglandins or leukotrienes. These leukotrienes also tend to cause bronchoconstriction, and this is via LOX pathway and this is via COX pathway. Prostaglandins in this via COX pathway and this leukotrienes in this via LOX pathway. Clear? And bronchoconstriction can also be mediated by other important agents like adenosine. Clear? These can also produce bronchoconstriction. At the same time, your mast cells can also produce bronchoconstriction through histamine release. Mast cells also can activate and produce histamine. By that also they can produce bronchoconstriction. So there are a lot of areas that where you can get bronchoconstriction. At the same time, one of the other important things that is important for producing a bronchoconstriction is inflammation of the bronchus. Inflammation of this airways also is one of the main reasons. Because of that also the airway diameter is reduced, and because of that your airflow resistance is increasing. So our drugs are going to target these areas only. For example, you can actually block this muscarinic area. So let us put in different color. So you are blocking this muscarinic receptors, and that's what your muscarinic antagonists are doing. So muscarinic antagonists are typically two types. One is called short-acting muscarinic antagonist, that's called SAMA, and long-acting muscarinic antagonists are there, that is called LAMA. So you can avoid the bronchoconstriction and you can produce more bronchodilation. And your inflammation can be prevented by giving steroid drugs. And to an extent you can produce bronchodilation. And steroids work better in asthma compared to COPD, which you have seen already. And you can stabilize these mast cells from releasing this histamine. These are mast cell stabilizers. Mast cell stabilizers, which are nothing but chromoglycate, sodium chromoglycate, and we have another drug called nedochromil. So these are the mast cell stabilizers and less popular. It's not so common at all. And this leukotriene can be blocked from their action. These are leukotriene receptor antagonists. Leukotriene receptor antagonists, and these are two drugs are there, montelukast and zafirlukast, right? I'm telling about the general drugs that are used in asthma and COPD. And you can block the LOX enzyme also, so that you will produce less amount of leukotrienes. And these LOX inhibitors are nothing but Xileuton. And again, it's a less popular drug, very, very less popular drug, Xileuton. Or you can give a beta 2 stimulation. You can do a stimulation of this beta 2 receptor directly by giving beta 2 agonists. This again, you can split into short-acting beta agonists and long-acting beta 2 agonists, SABA and LABA. Two types are there. Or you can block this phosphodiesterase enzyme so that you can increase the levels of cyclic AMP so that you can produce more bronchodilation by mimicking more sympathetic action inside the bronchus cell. So phosphodiesterase inhibitor, non-specific and non-selective phosphodiesterase inhibitor is there. That is called theophylline. And you have PDE4 inhibitors, specific phosphodiesterase 4 inhibitors. And again, this is bronchospecific. That's why this specific bronchospecific phosphodiesterase 4 inhibitors are what we called as roflumilast and silomilast. Roflumilast and silomilast. Clear? Remember, this roflumilast and silomilast are effective only for COPD patients. It is not effective for bronchial asthma patients. Clear? So what are the drugs that you can use typically for COPD, more effective in COPD? Your muscarinic antagonists are more effective in COPD, and roflumilast and silomilast are more effective in COPD patients. But on the other hand, your beta-2 agonists are more effective for bronchial asthma. Steroids are more effective for bronchial asthma. And your montelukast is more effective for bronchial asthma. Your mast cell stabilizers are more effective for bronchial asthma. Ziluton again is more effective for bronchial asthma. So which means only this PDE4 blockers and LAMA are really effective for COPD compared to that of bronchial asthma. But other drugs are generally more effective for bronchial asthma compared to COPD. But beta-2 agonists are combined. You can write in both actually. You can write in both. Even for COPD they do well. But anyway, the LAMA and PDE4 inhibitors are typically for COPD. Steroids is typically for bronchial asthma. I mean, both can be used. I'm not telling you cannot use. But anyway, this is how you have to remember. And how aspirin produces exacerbation of lung disease? By the fact that aspirin is going to block the COX pathway. Once it blocks the COX pathway, arachidonic acid will be shunted towards producing more and more leukotrienes, which means they can produce more and more bronchoconstriction. This is what we call it as currently aspirin exacerbated respiratory disease. So previously you had known about GERD, but you have not heard of the term called AERD. So this is nothing but aspirin exacerbated respiratory disease. Any respiratory disease can be exacerbated by aspirin, by this mechanism of action. So these are the general overview of drugs that produces bronchodilation. Adenosine we'll discuss because this is a cardiac drug. We are going to use in SVTs, and one of the important contraindications bronchoconstriction because it produces bronchoconstriction. That is the reason. So these are the overview of the drugs. Now let us go. What are the drugs that are typically used in COPD? So let us go for the bronchodilators first. Let us see the bronchodilators first. We can classify into two. One is called a short-acting bronchodilators and second one is long-acting bronchodilators. Under the short-acting bronchodilators, you have short-acting beta-2 agonists and you have a short-acting muscarinic antagonist. Short-acting beta-2 agonists, you have typically salbutamol, otherwise referred to as something called a albuterol. Salbutamol, otherwise referred to as albuterol. Both are the same. Then you have levosalbutamol, otherwise referred to as levoalbuterol, and phenoterol. This is also very commonly used nowadays. Then short-acting muscarinic antagonist, only one drug is there, that is called ipratropium. Then long-acting bronchodilators, you can divide into long-acting beta-2 agonists and you can divide into long-acting muscarinic antagonists. Long-acting beta-2 agonists, you can give, like either twice daily formulation or once daily formulations. There are certain twice daily formulation, typically your salmeterol and formoterol. So these are twice daily formulations. What are once daily formulations? You have indacaterol, you have olodaterol, and you have vilanterol. So these are the once daily formulations. All these are used in current practice anyways. LAMAs, again, you have once daily formulation and twice daily formulation. Let us see the twice daily formulation first. Typically, you have two drugs. One is called aclinidium and glycopyrrolate. Then you have once daily formulations also. That is tiotropium. Very, very famous, tiotropium bromide, and you have omeclinidium. These are once daily formulations. In India, the famous things are salmeterol, formoterol, tiotropium, then salbutamol, formoterol, levosalbutamol, ipratropium. All these things are very, very, very common and routinely used by many pulmonologists and physicians. So that's why it's important to know these drugs. So first, over bronchodilators. Second, you have inhaled corticosteroids, ICS. What are the inhaled corticosteroids that we typically use? One is budesonide. Second one is fluticasone. And third one is beclomethasone. That's it. Third one, I told you have phosphodiesterase 4 selective inhibitors. Already we discussed about that. Roflumilast and cilomilast. Roflumilast is the one that is currently commonly used in India. Then you have systemic steroids in COPD. But remember, systemic steroids you should use only during exacerbations. Only during exacerbations. That's it. You should not use in any other condition apart from exacerbative purpose. Only during exacerbations you will be using this systemic steroids. That's it. But do you know the fact that all these treatments you are using are only for symptomatic therapy? None of these treatments is going to improve your survival. Very, very important. None of these treatments which I have told is going to improve the survival. I told you only two things will improve survival. The best, smoking cessation, and second one is long-term oxygen therapy. So keep that in mind and read all this. Then you have other treatments are there. Other treatment options, characteristically theophylline. Theophylline is a non-selective phosphodiesterase inhibitor, basically. Typically in COPD nowadays, we have moved out of theophylline. Even in bronchial asthma, even in COPD patients, we have moved out of theophylline. Nobody uses theophylline in the current era. But to be honest, theophylline can still have a role in exceptionally refractory disease to an extent. But why we have removed out of the market is because of its side effects, because it has got a huge side effects, theophylline. What are the side effects? First one, it can cause refractory nausea and vomiting with severe abdominal pain. Number one. Number two, it can produce severe tachycardia and it can progress to severe arrhythmias as well, especially atrial fibrillation. And they can cause CNS toxicity also, and a very, very important CNS toxicity is tremors. Apart from that, they can produce agitation, they can produce insomnia, they can produce psychotic symptoms also. Psychiatric symptoms also. They can produce hypoglycemia as well. They can produce hypoglycemia also. Remember, beta-2 agonists also can precipitate hypoglycemia, and especially beta-2 agonists can precipitate hypokalemia also. Why? Because your beta-2 agonist, especially this beta-2 agonist, especially if you are giving by systemic route, not by inhaled route, systemic route is more effective. If you are giving by injection, especially IV or subcutaneous route, they can rapidly produce hypokalemia and hypoglycemia. Both are possible. Why they produce hypokalemia? Because these drugs, beta-2 agonists, will activate sodium-potassium ATPase. And by activating sodium-potassium ATPase, they are going to push the potassium into the cell, which means it's a transcellular shift. So theophylline also can produce hypoglycemia for that matters. That is due to increase in the insulin secretion. And they can produce hypotension, seizures, and all these things if the patient is having a severe toxicity. But remember, theophylline, one good thing is it's a dialysable drug. It's a dialysable drug. It's amenable to dialysis. And contraindications to theophylline, very importantly, patients who has a high risk of arrhythmias, who has MI recently, and patients who are having HOCM. HOCM is a definitely contraindication. You cannot give theophylline there. Contraindication is HOCM or any other cardiomyopathy for that matters. Patient who was having an MI or recently had an MI, or patient who is having tachyarrhythmia or prone for arrhythmias, you should definitely not give theophylline. There is no doubt about that. At the same time, theophylline is also more prone for significant drug interactions because it is metabolized by cytochrome enzymes, which means they can interact with ciprofloxacin, clarithromycin, and a lot of enzyme inhibitors can increase the levels of theophylline in the blood by reducing the metabolism. Like typical example is clarithromycin, very commonly used in acute exacerbation. During acute exacerbation, you use clarithromycin and you give theophylline also to the patient. Clarithromycin will inhibit the metabolism of theophylline, and theophylline levels will rise without any restriction, and you might result in development of arrhythmias in AF. So whenever in exam a COPD patient treated with clarithromycin and theophylline develops AF, think about a drug interaction. That is due to drug interaction. This is a common exam scenario also. Then in the other treatment, you can use pulmonary rehabilitation. Pulmonary rehab. Don't think incentive spirometry. Incentive spirometry is not a pulmonary rehabilitation. Clear? Pulmonary rehabilitation, and again it doesn't mean a chest physiotherapy. That is also doesn't mean a pulmonary rehabilitation. Pulmonary rehabilitation means a good exercise program and good breathing exercises. That is what we mean by a pulmonary rehabilitation exercise, because these patients will be deconditioned very badly, COPD pain, especially those who are suffering from emphysema. So to improve their muscle mass and improve their muscle tone, you need a good exercise program, because their respiratory muscles are really important. If they are deconditioned, they're going for cachexia slowly, the respiratory muscles will be very weak and they cannot, do a proper breathing, and they'll go for more and more respiratory failure in due course. To protect the respiratory muscles from going for deconditioning, you need this good exercise program, and their body also need to be in a good fitness. So that is why you do a good, this graded exercise regimen and breathing exercise and all these things we give, and that's what we call it as pulmonary rehabilitation. Indications: all patients with GOLD B, C and D need pulmonary rehabilitation. And second, at the same time, all patients who are symptomatic with an FEV1 of less than 50% need pulmonary rehabilitation. Remember, even if it's asymptomatic, you can give in certain patients. In all patients who are symptomatic with FEV1 less than 50% needs pulmonary rehabilitation therapy. And finally comes your long-term oxygen therapy. I told you already, LTOT is one of the treatments that improves survival and alters the natural history of COPD patients. So this is called long-term oxygen therapy. What are the indications of long-term oxygen therapy? We'll give a low flow oxygen, approximately 1 to 2 liters per minute of oxygen we give through nasal prongs, and it has to be given at least for a minimum of 15 hours a day. The more you give, more the benefit, according to many criteria and trials. Indications: number 1, if your PaO2 is less than or equal to 55 millimeters of mercury, or if the arterial saturation of oxygen is less than or equal to 88%. Number 2, if the PaO2 is less than or equal to 59 millimeters of mercury, or if the oxygen saturation is less than or equal to 89%, but plus, because this you need, because otherwise both the criteria will be mismatching. Plus, you should have additionally at least one of carpulmonale or polycythemia. Any one is needed. Any one along with this criteria. First one is independent. Second one is dependent on other things like carpulmonale and polycythemia. Polycythemia means hematocrit more than 55% according to COPD standards. So any one if you have, along with this, again they qualify for long-term oxygen therapy. Remember, it has to be given at least for, as I told you, 15 hours per day, at least continuously, and it has to be continuous. Remember, the more you use, even you can use 24 hours a day also. The more you use, more the impact and more the benefit. That's it. But you should not use less than 15 hours a day. There is no impact on survival. And finally, and remember this LTOT indications which I told you, it applies for any lung disease. Even it applies for your IPF also, idiopathic pulmonary fibrosis also, ILD patients also, for even many patients with other lung diseases also, you can apply the same criteria for LTOT, long-term oxygen therapy. So this is not the criteria only for COPD. Be clear about that. Then surgical treatment of COPD. What are the surgical aspects of treatment in COPD patient? You have typical endobronchial valves, which I'll discuss in some time. Endobronchial valves. So this is referred to as bronchoscopic LVRS. Bronchoscopic LVRS. And number 2, you have surgical LVRS. LVRS are there. Surgical LVRS has two types again. You have resectional type of LVRS and a non-resectional type of LVRS. First of all, what do you mean by LVRS? We have been talking in so much in terms about LVRS. What do you mean by LVRS? It is called lung volume reduction surgery. So why lung volume reduction becomes really important in a COPD patient? The reason why lung volume becomes so important in a COPD patient is because certain areas, and again COPD is asymmetric. Don't think COPD is a very symmetric disease. It generally tends to be a very asymmetric disease. Asymmetric in the sense, COPD patients may have lot of areas, not of different areas, because I told you upper lobe is mostly affected by centri-acina type, lower lobe is affected by pan-acina type, which means it's not very symmetric. It's going to affect certain areas, not all the areas, very commonly the upper lobe. So what you can see is these areas that are hyperinflated in COPD, and these hyperinflated zones does not expel air properly, and they will be hyperinflated for long term. And they have very low vital capacity also, those areas that are hyperinflated. And especially these hyperinflated areas are going to compress on the other normal segments. So these hyperinflated areas will prevent the expansion of the normal alveoli also. So that is the idea basically. So actually what you can do is you can try to reduce the hyperinflated areas. You can deflate these areas by removing this area or do something and deflate this area so that the other normal areas can expand properly. Which means these hyperinflated areas restricting the other normal areas is what the problem. And that is also one important reason for the dyspnea and reduced vital capacity in this patient. So deflate somehow, either by removing or not removing, some mechanism will deflate those hyperinflated areas, and you will have a good expansion of the normal lung so that you will not have that much dyspnea, and the quality of life in the COPD patient will improve. That is the basic reason why we do a lung volume reduction surgery. First of all, resectional LVRS means we try to cut that particular surgical. This is surgical therapy. So this is surgical LVRS. So we do a thoracotomy, we cut that area and we remove that part of the lung that is hyperinflated. That's called resectional LVRS. Non-resectional LVRS is very simple. We just, don't cut the lung. Instead, we are just going to leave the lung there itself. We are not going to take it out. We are just going to deflate that zone by surgery, and we just put staples and isolate that area from the rest of the normal lung, and we just leave inside the chest wall itself. That's called non-resection type of LVRS. But both these things are currently superseded by this bronchoscopic LVRS. Let us see how bronchoscopic LVRS is being done. But before that, what are the indications for LVRS in general? First of all, you have to, more than the indications, you have to know what are the conditions where you have to avoid this LVRS, which means contraindicated LVRS. Number one, non-upper lobe disease. Remember, upper lobe is the one that has the highest VQ ratio, which means less ventilation, less perfusion, both are in the high upper lobe only. If you remove the upper lobe, the patient will not suffer from significant issues. But you remove the lower lobe, the patient is going to get serious problem, because lower lobe is the one that's having maximum ventilation, maximum perfusion, and that's the one that's going to maintain your VQ in the first place. So removing the lower lobe is not a good idea, and it's going to further worsen the patient. So non-upper lobe disease is definitely a very, very big contraindication for removal of that particular area. You cannot do LVRS. Then, if COPD is due to alpha-1 antitrypsin deficiency, and that explains the fact, because alpha-1 antitrypsin deficiency will be pan-acina type, which will be involving the lower lobe, it will be non-upper lobe disease only. You cannot do that. And typically, LVRS is not known to be beneficial in these patients as well. Number 3, if FE1 is less than 20%, which means it's very, very, very low, poor quality of life, you cannot do that. Patient will not tolerate the surgery. And if DLCO is less than 20%, very, very, very poor prognosis, and again, patient will not tolerate the surgery. Anyway, patient will die. You don't kill the patient on table by doing these fancy surgeries. So that's why these 3 are absolute contraindications, and this is what you have to know for exams. You should not do this LVRS if you have any one of this. Then, coming to what are the endobronchial valves. So endobronchial valves, you can see here. So these are the endobronchial valves. These are what we refer to as bronchoscopic LVRS. These are one-way valves typically. First thing you have to know, these are one-way valves. What I do is, Suppose, let us assume this particular segment is hyperinflated. This particular area of the lung is hyperinflated. And what I'm going to do is I'm going to put a one-way valve here. So let us assume this is a one-way valve. That is bronchoscopic valve, endobronchial valve that I'm placing here. And this one-way valve means this will open only during expiration and this will not open during inspiration. This will close during inspiration. When I'm inhaling, valve will close. When I'm exhaling, the valve will open. It's a very intelligent one because when you place the valve in that main bronchus in that particular section of the lung, what's going to happen is it's going to open only during expiration, which means the air is going to move out of this particular hyperinflated region only during expiration. And during inspiration, air will not move in at all, which means you are effectively deflating this area. Simple, very brilliant. So which means now here you can see this an expiration, this an inspiration, where the valve is opening and the air is coming out during expiration, but no air flows inside during inspiration, which means you are deflating that zone in a very smart way. That's why this is becoming one of the very upcoming treatments among the LVRS section. Instead of doing such a morbid procedure like opening and removing all these segments, instead you can do a bronchoscopic procedure itself. LVRS, lung volume reduction surgery. Then you can go for a bullectomy. What do you mean by a bullectomy? Removal of the bulla. That's it. But it's very rarely done. It's not a surgery that's very commonly done, very rarely done. Only one indication is there. You should have a single large bulla occupying at least more than half of the hemithorax, which means more than 50% of the hemithorax. If it occupies a single large bulla, then you can resect that. That's called bullectomy. But apart from that, very rarely done procedure, very morbid procedure also. Finally comes the lung transplantation. Lung transplantation. Lung transplantation is still not so common in COPD because of many trials clearly proving there's no change in the survival, which means survival remains the same whether you do lung transplantation or not. But it still improves the quality of life. That's why still it can be an option. It nicely improves the quality of life, but it doesn't change the survival any bit compared to your medical therapy. So I told you again, only two treatments that improve survival is your LTOT and smoking cessation. Lung transplantation is not. And COPD remains the second most common cause of lung transplantation. If somebody asks you in the world what is the most common cause of lung transplantation in the world, you have to answer idiopathic pulmonary fibrosis, IPF. That's the most common cause in the world as of now. India don't have data, but COPD still remains the second most common cause of lung transplantation in the world. What you have to do is, whether you have two types, one is called a double lung transplant, both lungs can be transplanted, or a single lung transplant, SLT. Most commonly done procedure is a double lung transplant rather than a single lung transplant. And double lung transplant improves the quality of life much better compared to the single lung transplant. So preferred is the double lung transplantation. Both lungs can be transplanted. So survival after this double lung transplant is approximately 7 years, and after single lung transplant is approximately 5 years. And this survival benefit is more if the patient is having an alpha-1 antitrypsin deficiency. Even more survival, which means it's good actually. For alpha-1 antitrypsin patients, it works even more better. At the same time, age more than 60 is a contraindication. You cannot do, because this is not a good procedure for them. They're already dying. And if they're having such a less life expectancy, and there's no point in doing such a expensive and morbid procedure. So not needed. So age more than 60 is a contraindication. Clear? So I told you two things that are going to improve the survival in COPD patients, or are going to alter the natural history of COPD, is smoking cessation and LTOT. So let us see the smoking cessation first. Smoking cessation first. It's a cornerstone of treatment. Every patient should stop smoking. But even though they don't listen to you, but still you have to tell them somehow and to stop their smoking. Otherwise, they are not going to survive for long. So to help in smoking cessation, the first thing you need is the counseling part. Counseling and assessment. So typically we follow a strategy called a 5-way strategy. That's what we follow. One is ask, advise, assess, assist, and arrange. Those who fail this initial strategy are candidates. Those who fail this 5A initial strategy, they are candidates for drugs. Obviously, and no doctor, not only here, no doctor will like this. They only like this because you are doctors. That's why you like this. But I feel this is more important. 5A strategy and counseling assessment is more important. It really helps than the drugs. Simply giving drugs don't work most of the time. So you have to be a doctor. You are a doctor because you are you are someone who understands the empathy and sympathy of others, and you are not a pharmacy. You are a living person. You are a doctor. So please talk to them. So assess and counsel them, and really it helps. I've seen a lot of patients who quit smoking, in fact, because you provide the willpower sufficiently. Okay, drugs. How drugs can help? Let us see. So the drugs for smoking cessation, characteristically, there are many different types of drugs. The first drug is nicotine itself, nicotine replacement therapy. Please be very clear that addiction is due to nicotine only, but the effects of other chemicals are very important in causing damage to your body. But nicotine is the one that provides addiction. So giving a good nicotine replacement might result in reduced withdrawal symptoms, and it can actually help in removal of that addictive potential also. So that's why the first drug we are going to see is the nicotine itself in the form of nicotine replacement therapy. Nicotine replacement therapy. So we can see the mechanism of action, we can see the side effects of this drug, at the same time we can give some comments. As usual, my favorite table. So mechanism of action, it's going to act on the nicotine receptors. It is going to stimulate the nicotine receptors so that you have reduced withdrawal symptoms even if without a cigarette smoke. Reduce withdrawal. Side effects, mostly local side effects only, depending on what formulation you are using, because this nicotine replacement is available in the form of patches, very commonly used in the world, but in India, certain areas patches are not available because of the fact that it causes severe local irritation. Because of that, some areas have banned these nicotine patches. I don't know why it's such a good drug. Patches, then you have gums, then you have lozenges, then you have sprays, then you have inhalers also. But in India, famous are the patches and the gums. In my hospital, due to weird reasons, they don't have patches because they cause severe local irritation in certain patients. So I use Nicogums because of no choice. Clear? So obviously it will be local problems, especially skin related problems if you are using a patch. Apart from that, insomnia, vivid dreams, all this due to CNS stimulation. Comment wise, what I am trying to do is typically give a long acting patch. Long acting drug first, which is a patch, plus you can give a add-on short acting drug. So plus a short acting drug, I'll be give as a PRN formulation as an add-on. Gums or lozenges. So short acting means gums or lozenges. Long acting means patches. Patches you can stick it and it works for 24 hours. Next day you can replace them. But despite having the patch, they might have the craving for smoking. If they get that craving, if they get that thoughts, that time they can take a gum or a lozenge, which is a short acting one that reduces the craving at that point. So give a stable long acting drug on the background. On top of, like in between you get the cravings, that time you can suppress the craving by taking gums or lozenges. The classic dose of this patches, I don't know how much it's important for you. Patches typically depends on number of cigarettes. If more than 10 cigarettes per day, we will be providing 21 milligram per day patch. If it is less than or equal to 10 cigarettes per day, we will be giving 14 milligram per day patch. And again, Nicogums, depending on the cigarettes, less than 20 cigarettes per day, we'll be using 2 milligram patch 2 milligram gum every 1 hour. Every hour you can use. That much you can use nicotine, no problem at all. This is all about nicotine replacement therapy. Second one, we have a drug called varenicline. Varenicline is a partial nicotine receptor agonist. Partial nicotinic receptor agonist. typically acts at the alpha 4 beta 2 nicotinic receptor. That's what it's going to act. Mechanism very simple. Since being a partial nicotinic receptor, it occupies the receptor and prevents the withdrawal symptoms. Because if the receptor is not occupied, then only you will get the withdrawal symptoms. Here, the nicotine, varenicline is going to go and occupy the receptor, but at the same time, it prevents the reward due to nicotine, because nicotine is a full agonist. It activates a lot of downstream pathways and activates the reward mechanisms, and that is the reason why you get the addiction. So this varenicline, what it's going to do is it's going to go and occupy the receptor, which means you don't get the withdrawal symptoms. At the same time, it doesn't activate any downstream pathways. So which means you are not going to get the reward effect of nicotine. So you can use this for de-addiction. So that is the idea. So varenicline. But side effects, nausea and vomiting, abnormal dreams, headache, skin rash, and neuropsychiatric problems, typically suicidal thoughts. Neuropsychiatric, and this is a very important exam point because this is contraindicated in patients with suicidal ideations or psychiatric problems. You should not give. Very, very important contraindication because it can induce suicidal ideations and suicidal thoughts. So, what are the comments? I told you it's a dual acting drug, which means it reduces withdrawal also. At the same time, it reduces the reward effect of smoking, the addiction potential, the reward effect of smoking also it will prevent because it's a partial agonist, not a full agonist like nicotine. And second thing, it's an oral drug. Third one, you have to avoid this. Definitely it's contraindicated in patients with psychiatric problems. Typically, those with history of suicidal ideation should never give this varenicline. Very, very important point. This is a multiple times asked question also in exam. Number 3, you have bupropion. Bupropion is a nicotine receptor antagonist. At the same time, it also is a noradrenaline and dopamine reuptake inhibitor. We can call it as NDRA, nicotine receptor agonist. At the same time, it's a NDRA also. What do you mean by NDRA? Noradrenaline and dopamine reuptake inhibitor. That's what this bupropion's mechanism of action is. To be honest, bupropion is a natural antidepressant. It was an antidepressant medication, which later on turned out to be anti-smoking medication. That's how it is. So bupropion wise, the side effects typically is insomnia. Again, they can cause agitation, headache, and dry mouth. I'm telling only the important effects. There are more than 50 side effects of bupropion, but these are the very important side effects. Dry mouth. In that PJ question was this dry mouth only. Bupropion. Apart from that, there are some good and bad things about bupropion. Like for example, bupropion is one agent. It's not a side effect, but they promote weight loss. They cause weight loss. And this is actually an advantage in patients who are going for smoking cessation therapy because there is significant weight gain in patients who are doing smoking cessation. And this is a very important thing to know that this is called as post-smoking cessation weight gain. And giving bupropion is beneficial in these patients because they don't go for weight loss. Clear. And it's a natural antidepressant. Natural antidepressant. And again, it's very important because many patients who go for smoking cessation are getting depressed. And this is a natural antidepressant and hence you can use. Definitely. And it is also an oral agent and it is contraindicated in patients with known case of seizure disorders. Remember, bupropion reduces the seizure threshold. You can write in the side effects also. But remember, this is an exam question again. Like how I told, contraindicated in psychiatric medications. Contraindicated in this varenicline is contraindicated in psychiatric problems. Like that, bupropion is contraindicated in patients who are having seizure disorder because they reduce the seizure threshold. So these are the various anti-smoking medications that you can use. Apart from that, you have other anti-smoking medications. There's a second-line anti-smoking medications like nortriptyline. Nortriptyline, it's a TCA. You have cytisine. The mechanism of action of cytisine is similar to that of varenicline, partial nicotine receptor antagonist. Then a lot of other therapies are there with unproven benefit, like clonidine, SSRIs. Then you have something called e-cigarettes. E-cigarettes, you have a battery and an aerosolized nicotine, and it delivers a fixed dose of nicotine as an aerosol. So it is only going to deliver aerosol. It is like a nicotine replacement therapy only. But currently there are conflicting results. In terms of like your benefit when you are giving e-cigarettes. But some trials are telling nicotine replacement therapy is superior. Some trials are telling this e-cigarettes, if it's given with proper willpower and proper counseling, these e-cigarettes are better. But again, it's a lot controversial. Whether to use these e-cigarettes or not is very controversial. And how these e-cigarettes will look, you can see this is how they're going to look. Clear? So this is a battery device you can have here. This is an usual cigarette. That is not it. This is an e-cigarette where you have a battery device. Inside that you have an aerosolized nicotine. So when you take a puff, it will give a controlled amount of nicotine. But remember one fact, this is the latest trial in 2019 that is done. A good behavioral support along with e-cigarettes is better than NRT, better than nicotine replacement therapy. That's what I think, I forgot the name of the trial, but in 2019 it was done, and that's what it's been proved. If you give a good behavioral support with e-cigarettes, it is better than nicotine replacement therapy. So a lot of conflicting results are there, very controversial, but still you can see if you get this kind of images in exam, you can answer this as e-cigarettes. And only one more treatment is there. One more thing that is left is management of acute exacerbations of COPD. How you are going to manage acute exacerbations of COPD in the first place? So first you have to know how to diagnose an acute exacerbation. How will you diagnose an acute exacerbation? There is a gold definition for that. So gold definition clearly tells, number one, whenever your cough increases or changes in severity and frequency. Second, your sputum either increases or changes in its character, like even a change in the character of the sputum, like change in the color and consistency of the sputum. If it becomes more and more purulent, that also is an indication for exacerbation. Or the patient might have increasing shortness of breath that is not responding to standard and their regular medications that they are using in home. These are all the indications for COPD exacerbation. It can be mild, it can be severe also. So clinically mild, they will just come with these features. If they go for severe exacerbation, they can come with a frank type 2 respiratory failure also, where they'll be having low PaO2 with a very high PaCO2. In worst case scenarios, they can even come with the CO2 narcosis if the PaCO2 levels exceed 80 or 90 millimeters of mercury. Complete coma and somnolent stage. That is also possible. So, what are the treatment you are going to give? And what are the causes of this exacerbation? We have not discussed about. The most common cause for this exacerbations are infectious causes. And in the infection, most common will be Haemophilus influenza. That's going to be the most common. Apart from that, you can get from pneumococcal infections, or even drugs can cause, like beta blockers, certain allergens can cause, pollution can cause exacerbation, stress can cause exacerbation, continuing smoking can have increased risk of exacerbations. A lot of explains are there, but exam point will be this Haemophilus influenza, which is the most common infectious cause for exacerbation. Even viruses can cause exacerbation. I didn't write that, but still it's important. So these are the important things that cause acute exacerbations. Apart from that, what is the best predictor? The best predictor that predicts that the patient will get future exacerbations. History of prior exacerbations. Note it down. That is the best predictor to tell that the patient will get next exacerbation faster. History of past or prior exacerbations. Very, very, very standard and important point. That's the best predictor. So how will you treat? Let us come to the treatment now of acute exacerbations. And all patients should receive your nebulizations. Usually we give a SABA plus SAMA nebulizations as needed. PR. Clear? So you can give inhalers also alternatively, but ideally, like in during exacerbation settings, it's better to prefer nebulizations. But there are a lot of trials which have proved inhalers are not inferior to nebulizations, but it's a standard thing to prefer nebulizations in hospital settings. Next thing, you have systemic steroids. Remember, the only indication for systemic steroids in COPD is during acute exacerbation. At any cost, in a stable patient, you are not going to give systemic steroids at all. Only in patients who are having exacerbation, you can give systemic steroids. Remember, you have to give oral or IV steroids. Inhaled corticosteroids, already they don't work well in COPD. That too in exacerbation stage, definitely they won't work in COPD. So typically, I generally prefer oral prednisolone, generally 30 to 60 milligram per day dose for 5 to 14 days. But my standard practice dose in India is 40 milligram per day for 5 days. It works very nicely, especially if the disease is mild. Or you can use IV methylprednisolone or IV hydrocortisone also if the patient is inpatient and admitted in your hospital. And this is a very important treatment. Only indication of systemic steroids in COPD is this acute exacerbation. Then for admitted patients, typically for admitted patients, you can give O2 supplementation. Oxygen supplementation you can try. But remember, the targets for giving O2 should be very, very clear. You have to maintain an SpO2 in the range of 88 to 92% only, not more than that. Should not be over ambitious. At the same time, PO2 you should maintain at 60 to 70. Just more than 60 is enough. But remember, what if you maintain at 100%? You are going to result in a very important problem. Remember, if you are giving more O2, increase O2, it will precipitate increasing PaCO2 and the patient may go for CO2 narcosis. The CO2 levels may paradoxically rise if you give more and more O2. But why? Why this is causing a lot of issues and why you should not give more O2 in a COPD patient and you should maintain saturation at 100% or 90% like bronchial asthma. That is because of two reasons. 75% and 25% you can split. 70% of increase in PaCO2 is contributed by increase in the VQ mismatch. And 25% is contributed by something called Haldane effect. Haldane effect, you know that, very simple. Increasing O2 concentrations will increase CO2 release. That's all. So that is the reason how CO2 levels increase in this patient. That is due to Haldane effect, but only 25% is contributed by Haldane effect. But remaining 70% is contributed by VQ mismatch. Remember how COPD patients optimize VQ? By hypoxic pulmonary vasoconstriction. Suppose if this is obstructed and if this alveoli is poorly ventilated, let us assume is not ventilated properly, they will have hypoxic pulmonary vasoconstriction, which means the blood flow will be very limited here because of hypoxic pulmonary vasoconstriction, and the blood flow will be mostly targeted towards this alveoli only. So which means the blood flow will be mostly targeted towards this particular alveoli only, which is actually nicely ventilated. And with this alveoli only, you are going to have your oxygen as well as carbon dioxide exchange, which is now going to become a pulmonary vein. And they maintain VQ mismatch through this hypoxic pulmonary vasoconstriction only. But the problem is, if you are going to give more and more oxygen, suppose lot of oxygen, this excess oxygen will down-regulate the hypoxic pulmonary vasoconstriction, or it will decrease the level of hypoxic pulmonary vasoconstriction, which means now the circuits will become connected to the other side. Now the circuit will close because the blood flow starts happening. But remember, now the blood flow will be split equally into these two areas. But here the CO2 exchange is good. Here the CO2 exchange is happening, which means the CO2 is going on well through this alveoli. But now you are actually pushing CO2 through this alveoli, which is not getting ventilated, which means a lot of CO2 is going to come back and mix in the left side, which means you are actually increasing the CO2. Clear? Very, very simple. So which means you are worsening the VQ mismatch by giving oxygen in COPD patient. That is because you are overpowering the hypoxic pulmonary vasoconstriction, which is a very important thing in COPD patients. That's how they maintain the matching, at least to an extent. So don't do that. So that's why giving over-ambitious oxygen is dangerous in COPD patient. It can worsen the CO2 levels and they can push the patient into CO2 narcosis very fast. And the patients might collapse also. So next thing is the antibiotics. For all patients, almost. Indication for antibiotic, any change in the color, purulence, or volume of the sputum. You can give empirical antibiotics. Typically, we prefer giving macrolides. I told you already, clarithromycin as an example for interaction with theophylline some time back. So macrolides is what is typically preferred. I prefer clarithromycin for this purpose. You can prefer any macrolide. Typically, azithromycin is what many practitioners also prefer. So change in the color, purulence, volume, anything, even just a change in the color of the sputum may, push you towards using an antibiotic. Typically, most commonly used antibiotic is macrolide, but you can decide based on what is the severity of the infection. If it's a community-acquired pneumonia-like picture, then you can go for that particular protocol. So it's not something very standard and fixed. You have to understand. Number 5, mechanical ventilation, or you can go for positive pressure ventilation. Clear? So what are the indications for mechanical ventilation in COPD patients? Mechanical ventilation. Remember, first of all, you have to know what is the pH level and what is the PaCO2 level. First thing, indications for mechanical ventilation is increased work of breathing and or PaCO2 levels more than 45. What does that mean is, if you have any of this, it means patient is actually getting distressed and patient is getting fatigued and patient is getting exhausted. I told you in respiratory failure topic itself, whenever the patient is getting fatigued and exhausted, you should go for either NIV in the form of BPAP or you do intubation. That's it. So when you do intubation and when you do BPAP, the typical area where you give a BPAP, that is bilevel positive airway pressure, is when pH is in the range of 7.3 to 7.35, plus if the PaCO2 is more than 45 millimeters of mercury. With obviously this patient will have a clinical evidence of increased respiratory distress and increased work of breathing and all these things. So definitely in these patients you can give a BPAP, but please be very sure BPAP is contraindicated in patients with low Glasgow Coma Scale score, low GCS, because they cannot hold the mask. So in patients with CO2 narcosis, don't do that. So, or you can intubate the patient, no problem. You can intubate and mechanically ventilate if pH is less than 7.3, or if the patient is having contraindications to NIV. So in those conditions, NIV means in this condition it's BPAP. So in this condition you can give mechanical invasive ventilation also. Remember, pH 7.3 to 7.35 plus PaCO2 more than 45 is the standard and very, very important indication for BPAP. Clear? So remember, BPAP is something that reduces the number of days of hospitalization. So this is a very important treatment. And next, prevention of this acute exacerbation. Remember, you cannot use CPAP in COPD because you are giving for fatigue and exhaustion. You cannot use CPAP. We have discussed enough in respiratory failure already. So then what are the prevention techniques? Prevention by smoking cessation, pulmonary rehabilitation. This reduces the risk of exacerbations. Vaccination with pneumococcal vaccine and influenza vaccine, 2 most important infections causing exacerbation. So certain medications also can reduce the risk of exacerbation, like tiotropium have shown to reduce the risk of exacerbation. That is why LAMA first, always in COPD patients. And LAVA with ICS combination reduce the risk of exacerbation. N-acetylcysteine, roflumilast, phosphodiesterase 4 inhibitor, and chronic antibiotic therapy, long-term antibiotic therapy or chronic antibiotic therapy. Let me write as long-term antibiotic therapy with typically azithromycin, macrolide. So this trial is very controversial because they've given this azithromycin for 1 year and they showed that number of exacerbations reduced in that 1 year mark. After that 1 year, again the exacerbation come back to the original level. So which means only when you are doing azithromycin, during that point only you will have reduced number of exacerbations. But the moment you discontinue azithromycin, after that you are going to get more and more exacerbations as usual according to the risk of the patient. And remember, azithromycin usage is also associated with one other potential problem, risk of increased risk of resistant organisms. I told you antibiotic use in the last 90 days is one of the important risk factors for getting a resistant organism in community acquired pneumonia. So azithromycin use again is going to predispose to risk of resistant organisms. So that is why this is not followed by many practitioners nowadays, but still it is there. These are the agents, drugs that reduce the number of exacerbations or reduce the risk of exacerbations. That's why I'm telling under preventive techniques. Certain agents are not proven therapy in acute exacerbation, like theophylline, not proven. Then chest physiotherapy, not proven, that hitting on the chest physiotherapy, not proven. Mucolytic agents, again not proven. So all these things are not proven in COPD, exacerbation prevention. Clear? So with this, we are going to finally move to the prognostication. Prognostication is typically done with the help of Bode index. Bode index stands for the acronym. B stands for BMI, O stands for obstruction, which is typically assessed by FEV1, and D stands for dyspnea level, which is assessed with MMRC scale, Modified Medical Research Council scale, which you have discussed already. E stands for exercise capacity, which is typically assessed by 6-minute walking test. Remember, the score ranges from 0 to 10. This is the total score, 0 to 10. More the score, more the mortality. Especially if BMI is less than 21, again you are going to have increased mortality. Very, very cachexic patient. Total score is 0 to 10. Clear? You have other indices like Charlson index is also there. Charlson index, which is also used for prognostication of COPD. It might be a question in your exam. So this scoring ranges from 0 to 33, but less commonly used compared to the Bode index. In exam, you will be getting only Bode index as far as I know. So we are coming to a conclusion of COPD treatment, but before going into the final conclusion, I want to show you these two important charts. This is typically important. So this is the classic Fletcher-Peto curve. This is a classic Fletcher-Peto curve. This is one of the landmark curves in COPD diagnosis and treatment. What you are seeing is the green curve. This green curve, what you are seeing is the normal patient. So this patient has never smoked or not susceptible to smoke, which means they are smoking but they are not susceptible to its effects, or they have never smoked. You can see this is the FEV1 decline over the years, and you can see the FEV1 declines, but the rate of decline is what is very important. Remember, the rate of decline in these patients is approximately only 10 to 20 ml per year. Usually, rate of decline is only 10 to 20 ml per year in a patient who has not smoked at all or who is not susceptible to smoking. But you can see in a patient who is smoking, there is accelerated FEV1 decline. The FEV1 decline is more, and you can see the curve, comes very fast to the lower level. And a patient who is smoked regularly and susceptible to its effects. That's why I told you that point, susceptibility is very, very important. There are a lot of persons, not patients, who are not susceptible for smoking and its effects. So smoke regularly, at the same time it's susceptible to its effects also. Their rate of decline will be more, that will be approximately 40 ml per year, which means it's almost double to that of what you see in the patients who are not smoking. Their FEV1 decline will be more and more faster. Again, this rate of decline will vary with the stage of COPD. I told you average is 40 ml per year, but the rate of decline varies with the stage of COPD. But you can see in stage 1, it is 40 ml per year. In stage 2, it is 47 to 79 ml per year. In stage 3, it is 56 to 59 ml per year. And stage 4, again, it is approximately 30 to 35 ml per year, because you have already reduced so much, there is nothing to reduce faster after that. So these are the rate of decline. Again, I'm telling you, rate of decline is going to change this value of rate of decline of FEV1, but overall it is approximately 40 ml per year is the rate of decline in COPD patients. But what this curve tells is not all this thing. This is not something which is very important for me. What this curve is going to tell is a very, very standard fact that if you have stopped smoking, what will happen? If you have stopped smoking, what will happen? If you have stopped smoking at this point, your curve becomes the same as that of the person who has not smoked. Which means the rate of decline, the moment you stop smoking, will be similar to that of the person who has not smoked. Even if you stop at this point, you can see the rate of decline is similar to that of the person who has not smoked. Which means the moment you stop smoking at any point in your life, if you are a COPD patient, your rate of decline of FEV1 becomes equal to that of the person who has not smoked in his life. This is a very, very important and very interesting observation done by this Fletcher-Peto curve, and it's a very, 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 very important curve to know in your entire COPD treatment. That's why I told you the most important treatment that improves survival in COPD patients is smoking cessation, and smoking cessation. Thank you.